This is Dr. Lowe dictating the second of the screencasts for the second food to fuel case. This will deal with inflammatory bowel disease. These are chronic relapsing inflammatory diseases of unknown origin. They seem to be an abnormal immunologic response, which I believe is discussed in the immunology materials. There are two main forms, ulcerative colitis and Crohn's disease, although there is some overlap between these two. The etiology is unknown, and therefore they're called idiopathic. They are abnormal immune responses with epithelial dysfunction and genetic susceptibility. Genetic susceptibility is indicated by common family history, fairly high concordance in identical twins, and some specific polymorphism in nucleotide oligomer binding protein domain 2 gene in Caucasians of European ancestry, common in some populations. There is an abnormal T-cell response with exaggerated T-cell activation, probably not an autoimmunity. There are also epithelial defects that give access to bacterial antigens and altered immune response. These seem to be an abnormal response to normal flora, but there may be abnormalities in the access to that. Here's a cartoon of the immune abnormalities. Now, the first of the entities that we're to discuss is Crohn's disease. Used to be called terminal ileitis, but it really involves any part of the GI tract. Patients present with abdominal pain, fever, anemia, diarrhea, unless they have colonic involvement, in which case they may have bloody diarrhea. The involvement is discontinuous with skip areas, which will be illustrated in some of the diagrams later. Key features, again, to be seen are thickened walls of the bowel, fissures, fistulas, strictures, and perianal involvement. Inflammation is characteristically transmural, and occasionally granulomas can be seen. Granulomas are one of these features which are much described. They are fairly specific for Crohn's versus ulcerative colitis, but sometimes you have to look long and hard to find them, and even then, not every patient has granulomas with Crohn's. Ulcerative colitis patients usually present with persistent bloody diarrhea. It affects the colon only. The involvement is continuous. It starts in the rectum, is most severe in the rectum, and as it goes proximally in the colon, it becomes less and less severe. Now, this distribution can be altered by treatment, particularly steroid enemas, which will result in rectal sparing. However, ulcerative colitis does not involve the full thickness. The wall is not thickened. There are no fistula. There are no strictures. The mucosal inflammation is usually diffuse. However, there is crypt distortion, cryptitis, which is inflammation in the crypts, and crypt abscesses. Now, crypt abscesses are, for purposes of exams, considered to be specific for ulcerative colitis. However, they're not. They can also be seen in Crohn's disease. Here's a cartoon diagram of the distribution and features of Crohn's disease and ulcerative colitis. Crohn's disease has discontinuous involvement, here seen in red, with skip areas that are less involved. The wall in Crohn's disease is thickened. There are fissures, which may extend into the muscularis propria or even beyond, as we'll see. The wall of the bowel is thickened, subserosa is thickened, and there is this creeping fat. The mesenteric fat tends to involve more of the circumference of the bowel. Ulcerative colitis, in contrast, has more uniform involvement. The wall is not thickened. There are pseudopolyps, where the mucosa is not ulcerated, but you notice here the ulceration and inflammation stop sharp at the muscularis propria. Usually pretty sharp anyway. Here is a table from Robbins comparing the Crohn's disease with ulcerative colitis. Crohn's may involve any region. They say ileum, but it can involve any part of the bowel. Strictures, yes, the wall is thickened, we'll see. Transmural inflammation, these deep ulcers as opposed to the superficial ulcers with pseudopolyps in ulcerative colitis. Lymphoid reaction varies. Fibrosis and serositis occur in Crohn's disease, typically not in ulcerative colitis. Granulomas can be seen, sometimes can be hard to find. Fistulae and sinuses do occur with Crohn's, but not with ulcerative colitis. Perianal fistula and malabsorption can occur with Crohn's, depending upon the part of the bowel that's involved. Both have eventual malignant potential. Crohn's frequently recurs after surgery, so that the surgeons have to be careful about how much bowel they remove. Ulcerative colitis is limited to the colon, so if the colon is removed, that is, the patient should be cured. This is a gross specimen photograph of Crohn's disease resected bowel. There's really no scale on this, but you can see these hemostat clips here holding the bowel open, so you get some idea that the circumference of this bowel was no more than a couple of centimeters, which is abnormally narrow. Also, notice the wall is so thick that you needed 6 hemostats to hold the bowel open. The arrow points to this dark structure. This is a large linear fissure. And you notice that the mucosa was rather red. This is a photomicrograph. You can see some residual mucosa up at the left, very thickened lamina propria and submucosa with lymphoid follicles. The muscularis, this pink band, is also thickened with lymphoid follicles in the muscle. And really transmural inflammation, there are a lot of lymphoid follicles out in the subserosal fat. There's also fibrosis or fibrous tissue in the subserosal fat. These are some figures from Robbins illustrating features of gross pathology of Crohn's. Here you can see the narrowed bowel, the linear ulcers. In this case, there are multiple linear ulcers giving this cobblestone appearance. Sometimes the fistula can go all the way through the bowel. In this case, this is the outside, and there's a serositis, and here is the creeping fat. Microscopically, the Crohn's shows haphazard crypt organization. You notice these crypts are not uniform in size, space, orientation. This is a distinct feature of idiopathic inflammatory bowel disease that distinguishes it from the acute self-limited or acute infectious enterocolitis. Once the mucosa is completely destroyed, it will not regenerate normally, so that you see the irregular crypt architecture. On the right, you see some transmural inflammation, and down at the bottom you see a granuloma. Granulomas in Crohn's can be pretty subtle. That can be hard to find. This, in contrast, is the gross pathology of ulcerative colitis. The whole colon is involved, fairly uniformly and rather flattened mucosa. There can be an abrupt transition between involved mucosa on the right and normal mucosa more proximally. Here you can see the pseudopolyps, and occasionally there are webs that occur. Microscopically, ulcerative colitis has crypt abscesses. There is, again, loss of the epithelium here, and you notice that the disease here is limited to the mucosa. It stops. This is the muscularis propria, and it's fine. There is, again, gland distortion. However, there are cases where it can be difficult to determine whether a patient has Crohn's or ulcerative colitis. Here you see a photomicrograph. There's a nice, well, I don't know, nice, but there's a crypt abscess down here in the yellow circle and a granuloma in the green circle. Is this Crohn's or ulcerative colitis? Sometimes it can be hard to tell. A careful history occasionally will help you if the patient reports perianal fissures or fistulae or oral involvement, which will tip you off that the patient actually has Crohn's disease, even if the presentation is all colonic. Indeterminate inflammatory bowel disease. These have overlap between Crohn's and ulcerative colitis, it's about 10% of inflammatory cases. Over time, the patients may evolve to have more definitive diagnosis. The long-term risk in inflammatory bowel disease is dysplasia and colon carcinoma. It occurs with long-standing disease, severe involvement of the entire colon, and severe disease. Extraintestinal manifestations also occur with inflammatory bowel disease, including liver, skin or joints, and occasionally pulmonary fibrosis. Related to inflammatory bowel disease is irritable bowel syndrome. This is a chronic functional disorder that's fairly common. It's diagnosed by clinical criteria alone. There is no definite pathological abnormality. However, the workup needs to exclude infectious causes and also definite inflammatory bowel disease. Microscopic colitis. These are diseases that are limited to the colon but included here because they overlap in the differential diagnosis with inflammatory bowel disease. These are mostly middle-aged adults who present with watery diarrhea. There are two forms, lymphocytic colitis with lymphocytes in the lamina propria and collagenous colitis. I'll show both of these in this slide. On the left is lymphocytic colitis, and you can see lymphocytes in the epithelium and increased mononuclear cells in the lamina propria. Collagenous colitis, seen on the right at the top, you can see this thicker collagenous band under the epithelium. Here's a trichrome stain which stains the collagen blue, and you can see this thickened band there. That's all for this recording. Thank you.